Hello, everyone, and welcome to today's live broadcast, The Evolving Role of Microbiology Lab, COVID-19 AMS, and New Automated Technologies that Improve Rapid Diagnostics. I'm Susie Valdez of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by BD. For more information about our sponsor, please visit their site at bd.com. So let's get started. I want to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click on the Send button. Also, if you have any trouble seeing or hearing the presentation, report your problem by clicking on the Ask a Question box located on the far left of your screen. I'd now like to introduce our presenters. First joining us, Dr. James Snyder, Professor of Pathology and Laboratory Medicine from University of Louisville and Medical Director of the Clinical Microbiology and Molecular Diagnostics Laboratory at the University of Louisville Hospital. Also joining us, Dr. Romney Humphries, Professor in Pathology and Immunology at Vanderbilt University Medical Center and Medical Director of Microbiology at Vanderbilt University Medical Center. For a complete biography on our presenter, please visit the Biography tab at the top of your screen. Dr. Humphries, you may now begin your presentation.
Well, thank you so much, and thank you all for joining us today. So I'll be talking a little bit about antimicrobial resistance and some of the challenges that we've all faced in the clinical microbiology lab with regards to resistance during the COVID-19 pandemic. Here are my disclosures. And I'm going to start out with a case. So this case was from when I first started at Vanderbilt in August, where we had a 65-year-old man who was diagnosed with COVID-19 at an outside hospital. He was intubated, had high ventilation settings, deep sedation and paralysis, a very complicated course for COVID-19. He received many different therapies, including dexamethasone, remdesivir, vancomycin, and piperacillin tazobactam for presumed bacterial co-infections. And ultimately, he was transferred to VUMC at his family's request. When he came to us, he was septic, and he had a lot of sputum being produced with deep inline suctioning through his vent. And so you can see here his chest x-ray, where you can see a lot of consolidation in the right lung, as well as what we grew out of this was heavy growth of Acinetobacter baumannii. So, very classic for ventilator-associated pneumonia, one of the risks that we see with patients that are on ventilators for prolonged periods of time. So when we did susceptibility testing for this organism, unfortunately, as you can see on the left, this was a very resistant Acinetobacter baumannii. And so you can see based on the MICs here with our antimicrobials, the MICs shown, and it was resistant to every agent tested. And so the clinical team called the lab and said, this is a pretty difficult case for us. Do you have any thoughts on other antimicrobial agents that might have activity against multi-drug resistant Acinetobacter baumannii? And this is a question that comes up, every now and then, certainly sporadically during the pandemic, but even outside of the pandemic, where we're seeing these increasingly multi-drug resistant gram-negative bacteria. And so when we look at our options as far as newer antimicrobial agents, many different things came up. So the first was ceftazidime avibactam. This is a newer antimicrobial with activity specifically against carbapenemase producers. But when we look at this newer antimicrobial, the activity against multi-drug resistant Acinetobacters is actually pretty limited. The reason for this is it's not true carbapenemase production that's the main consideration for MDR Acinetobacter baumannii. And our isolate itself had an MIC of greater than 16. And this was a test that was done on our BD Phoenix MIC panels just as part of our routine testing. Another option that was floated was ceftolozane tazobactam, but this agent really does not have activity against multidrug-resistant Acinetobacter. And sure enough, you can see for our isolate, the MIC was greater than 32. A newer agent that has come to market is imipenem relebactam. Again, very limited activity in these cases in multidrug-resistant Acinetobacter with an MIC in our particular isolate of greater than 16. Meropenem vaborbactam is really a KPC drug, and again, no activity against MDR Acinetobacter. And the other thing that came up, and often we hear a discussion about it, is tigecycline. And tigecycline does not have clinical breakpoints for Acinetobacter baumannii. In fact, most of these agents I've mentioned just now do not. And really, MICs are in the 4 microgram per mil range typically for these organisms. And again, not a great agent for Acinetobacter. And so what we're left with are 2 newer agents, cefiderocol, which is siderophore cephalosporin, and in this case, the MIC was 0.5, and plazomicin, which is a newer aminoglycoside that does have activity against MDR Acinetobacter. And testing for this particular agent can be quite challenging. We actually were unable to get our isolate tested for plazomicin. And so, the bottom line here, just to comment on, these multi-drug-resistant Acinetobacters can be very difficult to treat, and despite a lot of really good antimicrobial development in the last 5 to 10 years that target these multi-drug-resistant gram-negatives, Acinetobacter baumannii, unfortunately, is an organism that's been left a little bit behind with very few agents that actually have good activity. So here's another case. This one is a much more recent case, and this was in February of this year. This is a 56-year-old man with diabetes, Crohn's, and asthma who's on some immunosuppressants. In early January, he was diagnosed with COVID-19. Unfortunately, his diagnosis took a little bit longer because this individual actually refused testing for COVID-19 up until the point pretty much when he was admitted to hospital. Again, he received a variety of different therapeutic options. You can see his CT scan here where his lungs are in very rough shape. They intubated him in mid-January, sent him over to us, and he's had many infectious complications associated with his COVID-19, including Candida glabrata in his blood, as well as, just like our past patient, ventilator-associated pneumonia due to a carbapenem-resistant Enterobacter cloacae in this case. So here are that individual patient susceptibility results. And so what you can see here is we performed on our Phoenix the CPO detect test, which said it was a class A beta-lactamase. This test provides information on the presence of beta-lactamases and their classes, if they're carbapenemases, for the enterics. We confirmed this with a PCR, which sure enough showed the presence of KPC. And very typical for KPC producers, it was resistant to the majority of agents that we tested, with the exception of ceftazidime avibactam and amikacin. And so in this case, we treated this patient with ceftazidime avibactam. Unfortunately for this patient, 2 weeks after he was treated with this drug, his isolate recurred, and it was now resistant to ceftazidime avibactam. And interestingly, the MIC for meropenem was now in the susceptible range. We confirmed the presence of KPC still in this isolate, and what we found through doing a little bit of additional work was that this particular isolate had mutated the KPC gene in the region called the omega loop, which is where avibactam binds, which leads to resistance to ceftazidime avibactam, but susceptibility to the carbapenems. Thankfully, in these cases, meropenem vaborbactam retains activity, and this is what our patient was treated with. So these 2 cases, I think, highlight some of the things that we were very concerned about at the onset of the pandemic with regards to antimicrobial resistance. And there is a fair amount of concern surrounding the management of patients with COVID-19 and the continued and maybe even accelerated emergence of resistance. What we do know is about 70% of patients receive antibiotics with a COVID-19 diagnosis, particularly those that are hospitalized. Only 4% of them actually have a true bacterial infection, and so there is a pretty big disconnect. And the reason that these patients are receiving antibiotics is simply because of an excess of caution. These individuals are quite ill, and we want to make sure that we're treating them to the best of our ability. And about 15% of hospitalized patients will develop a secondary bacterial infection like the two cases I just described. And so, the reasons for this use of antimicrobial include some issues with medical misinformation, particularly outside the United States. There's been a huge emphasis on the use of antibiotics, such as azithromycin, to prevent or even treat COVID-19. If you go to some countries like India, as an example, this is touted as a way to prevent infection with COVID-19, and you can go to your local pharmacy and receive azithromycin over the counter in those countries. And what we do see is that there is some evidence that because of these factors, resistance is increasing. And one study showed about a 10% increase in their antimicrobial resistance rates at their single institution when they compared the pre-COVID-19 isolates to the post-COVID-19 pandemic isolates. What's really interesting about the present pandemic is, unlike other viral pandemics where community-acquired pneumonia was a major cause of morbidity and mortality secondary to influenza, as an example, we don't see that as much with COVID-19. And so if you take a look at some of the, compare and contrast information, like I mentioned, community-acquired pneumonia was pretty prevalent in the 2009 influenza pandemic. And this was caused by nasopharyngeal colonizing bacteria that then led to secondary infections. And so quite frequently you would see pneumonia caused by Staph aureus, pneumococcus, or group A strep. All of these are colonizers that can then lead to community-acquired type pneumonia. In contrast, in COVID-19, what we're seeing, just like our two cases, is more instances of hospital or ventilator-acquired pneumonia, and these are hospital pathogens that are causing these secondary infections. The good news is that the incidence of this is significantly lower than what we would maybe see in other pandemics, but the organisms are more difficult to treat. So we're seeing gram-negative bacteria, a fair amount of Staph aureus, as well as some secondary infections caused by fungal pathogens. So when we take a little step back and think about the ways we can mitigate this increased incidence of antimicrobial resistance, the first thing, of course, is to continue to support the activities of antibiotic stewardship programs. In the early days of the pandemic, I don't know how many stewardship physicians I talked to who said, we've pretty much thrown stewardship out the window while we're trying to just manage the sheer scope of this pandemic. But we're seeing a significant return to those good stewardship principles that we follow in routine times. We also, interestingly, throughout the pandemic, have seen fewer outpatient physician visits. And so in countries where antimicrobials require a prescription, you actually have seen reduced use of antimicrobials in the outpatient domain. We're also seeing increased emphasis on hand hygiene, masking, and social distancing. And so all of these things help cut back the number of outpatient and even hospital-associated infections. And we want to, of course, continue the appropriate use of diagnostic testing. And so what we have seen in our own institution is many patients with COVID-19 never get a sputum culture done. And maybe this is because of the concern of collecting a sputum specimen for culture. And so they're being treated empirically rather than based on the lab-based data. And so this is an instance where increased diagnosis may, in fact, be helpful. Conversely, we went through a period where we were rejecting almost all of the sputum that came from patients on COVID-19 floors, and this was due to very poor specimen quality. And so again, there's not a lot of value in culturing saliva, even if a patient has COVID-19, just like there's not a lot of value to culturing that saliva if they don't. And so, following these good lab practices is really critical as we're, making our way hopefully through the end part of this pandemic. And so what can we do here in the lab? Well, I think that it's always important to be continually reviewing what we're doing from a susceptibility testing perspective and asking the question, is this sufficient for our population? And so by that I mean, are we testing newer drugs that maybe are needed if we're seeing a higher instance of resistance? And are those newer drugs addressing the pathogens that we're seeing? So in the first example, if you're at an institution that's seeing a lot of multi-drug resistant Acinetobacter, having the ability to either send out with some level of ease or do in-house Sufidral call testing might be an option that could really help your patients. Conversely, if you're seeing a lot of carbapenemase producers, having the ability to test those carbapenemase producing antimicrobials that act specifically against those carbapenemases is of value. And like I showed in the second case, susceptibility can never be just assumed by the presence of a given antimicrobial resistance determinant like KPC. The other thing we want to do is make sure that we're staying up to date with breakpoints. And this is a really big concern. We shared some data in an APHL webinar earlier this year that showed less than half of labs in the United States are up to date with even breakpoints that were set in 2010. So these are breakpoints now that are more than a decade out of date. And so you want to make sure that you're staying up to date with those breakpoints so the testing that you're doing in your lab is being interpreted by the right standards. And finally, and this is super important, and I talk about this all the time in my own lab, is we want to be constantly vigilant in reviewing our susceptibility test results. If something's not making sense, if there's unusual resistance or unusual susceptibility, that's something that needs to be investigated further before that patient report is put out. All right, so let's move to another case. This one was from September in 2020. This is a 4-day-old baby girl. Her mom had very limited prenatal care throughout the pandemic. And she was brought in by ambulance to our facility because mom noticed that she had quit breathing. And so when she came in, she was found to have bilateral purulent conjunctivitis with some conjunctival lesions. Her X-ray, which is a little bit difficult to see, I know, because it's so tiny, but showed interstitial fluid in both lungs. And so they started her on ampicillin and gentamicin, and when infectious diseases was consulted, they added on cefotaxime. Her sputum cultures and her eye cultures grew Neisseria gonorrhea, and sure enough, it turned out that mom was positive for Neisseria gonorrhea as well. And this is the second case that we actually saw just this month of a 36-year-old man with bilateral knee pain and rash. He was septic when he came into the emergency department, and his blood cultures grew gram-negative diplococci, which are shown on the gram stain. Again, a little bit tricky to see here, but you'll have to trust me. And this actually grew out Neisseria gonorrhea, and so this was a case of disseminated gonococcal infection. And so these are things that we're seeing with increasing frequency, and I truly believe that a lot of this has to do with reduced access to outpatient healthcare. And so there have been a lot of challenges with testing for COVID-19. We've all had issues getting pipette tips or test reagents or kits or what have you for COVID-19. But testing outside of the actual pandemic has also been very challenging due to supply limitations. And so some data from the American Society for Microbiology that's been trying to track this showed in January, 35% of labs were experiencing shortages of supplies for testing of sexually transmitted diseases like our gonococcal cases. You know, what really compounded this problem is that the culture media for recovering organisms like Neisseria gonorrhea was also unavailable. And then to even make it more challenging is that at that time there were national shortages for key drugs for the treatment of these sexually transmitted diseases, such as azithromycin, penicillin G, and actually the erythromycin ophthalmic ointment that is given to babies when they're born to prevent gonococcal conjunctivitis. And so all of these things really led to the types of cases that I just described in the previous slide. You know, it's not just sexually transmitted infections that are impacted, but we're seeing shortages across the board for a variety of different testing supplies. You can see here for bacterial cultures, mycology cultures, mycobacteria, parasites as well, all of these being challenging. And it really, as I'm sure those of you in the lab appreciate, fluctuates day to day, very challenging to deal with. It feels like there's a new issue every day. Like I mentioned, I believe that we're seeing some of these more disseminated cases. I've never seen this many in my career due to reduced access to outpatient care. And this has been noted in other countries. In Italy, the Italian group has done a nice job of publishing on this, where they've seen a decrease in the number of non-acute cases. So these are, more mild cases of chlamydia, gonorrhea, or syphilis, but an increase in the number of acute cases. And they really felt that, again, that this was due to patients who aren't seeking care when they suspect a sexually transmitted infection simply due to the restrictions imposed by the pandemic. So like I mentioned, we've dealt with a lot of testing shortages, and this has also impacted susceptibility testing. And I've kind of given a little bit of a list here to show you what we've dealt with recently. Actually, just this morning, we're dealing with a shortage of our test cards. And so you can see it ranged the gamut from Haemophilus test media, our RPMI auger that we used for Candida e-testing, the Mueller-Hinton auger, blood Mueller-Hinton auger, our susceptibility test system inoculation broth, all these different things. In the supply chain has been very difficult to manage. And so a lot of us have done, the best we can by swapping out our media or discs for alternative vendors. And, in normal times, we always talk about in normal times in my lab, but outside the pandemic, before you went ahead and swapped out manufacturers of one of these, you would maybe do a bit more of an extended verification to really be sure that you weren't going to see a big shift in your test results. In COVID times, however, often we just don't have the luxury to do that. And so the approach that we've been taking is more of a risk assessment type of approach to inform how we deal with these swaps. And so, we take a look at the types of risks, for example, a risk of false susceptibility, the likelihood of that by switching out, for example, Mueller-Hinton auger would be pretty low. The impact could be that the patient fails therapy. And the way we've addressed this through mitigations is carefully reviewing our QC, carefully reviewing our isolate results, and evaluating for any trends that we might see. Other types of things that we might see happen, if I jump down to changes in the MIC, well, subtle changes in our MICs might happen with a higher likelihood. And the impact of the patient could be maybe if you have a stewardship team that's really nuancing that MIC in the dose, they may be adjusting the dose incorrectly. And this is a lower risk, and so it would be just important to discuss MIC variability, not just in this time, but as a whole with your pharmacy and clinicians, et cetera. And I do want to just point out, there has been some nice data done both by CLSI and UCAS that's looked at failure rates for AST media. And even though these are not exempt media, the failure rate is really low, like 0.04% for Mueller-Hinton and 0.03 for blood Mueller-Hinton. So the types of things that might impact the Mueller-Hinton from manufacturer to manufacturer that could impact performance include subtle differences in pH, the auger depth, the content of divalent cations or thymidine. And so you can see here, these are some data from UCAS that took a look at a variety of different media, far more than I'm showing on this slide, but I'm just showing ones that are available here in the US. And they looked at their QC results for disc diffusion of being within a single millimeter from that target. And you can see that even across these different media, the majority of results are really tight, within a millimeter of that midpoint on the QC range. And if you looked at whether or not they were inside that QC range, it was 95%. The drugs they found the most impacted included trimsulfa, aminoglycosides, and fluoroquinolones. And so, the type of QC that you need to do when you're making a change to these media is outlined in M100 in the CLSI document. And so you can see here, if you're using a new manufacturer of disc, they recommend to just do a single day of QC. If you're using a new manufacturer of media, they suggest 5 days of QC. And so you can use this to point to where you're making these changes, how to do it. You want to review your QC data, and so this is some example of where we switched manufacturers and we went from weekly QC to daily QC when we switched the manufacturer. And what you can see here is that our gentamicin QC results for E. coli really didn't change all that much, but when we looked at our Pseudomonas aeruginosa QC strain, we did see a shift upwards in where those QC values were sitting. And so if you, again, go to that M100 document in Table 5G, there is some data that tells you what you might notice if, for example, you're seeing your Pseudomonas gentamicin QC being out. It could be related to the cation concentration in that media. And so what you might do then is take a look at other drugs that might be impacted by that calcium and magnesium content being a little bit off, and just keeping an eye on those particular drugs as you're going forward with your testing. So again, you know, it's not to overcomplicate this, but to just provide some general guidance and some troubleshooting for if you do start seeing changes or shifts in your trends. So a couple of thoughts, you know, that we've had to go through with our supply shortages is that we've had to, on a couple of occasions, triaged our testing. And so we've had to come up with plans for how to deal with, for example, shortages for our molecular tests for blood cultures and focusing on patients as a priority coming from the immunocompromised wards compared to other wards. You know, it's always a good idea to periodically review your SOP and to see if all the testing that you do routinely, if it's really needed. And so some of the things that we stopped doing throughout the pandemic, and I think we'll continue to not do, is susceptibility testing of candida isolates from genital specimens routinely, Haemophilus testing on every single respiratory specimen versus only doing it if it's indicated by that quality score on the specimen. And then testing of coagulase negative staph isolated from blood cultures. You know, you want to use the media you can get. It's the reality of this pandemic, but keep an eye out for trends and always try to be as practical as possible. So to summarize my little bit, antimicrobial resistance remains a concern. I think sometimes we miss this pandemic in the middle of the other pandemic we're going through. And as reduced access to outpatient care continues, we are seeing some interesting trends like the emergence of sexually transmitted infections or infections further along in the process than you might see patients presenting with otherwise. And we are all dealing with continued testing issues, and this is likely to keep going for some time yet. And so hopefully I've given some thoughts, at least food for thought, on how to approach these types of challenges. So I want to thank my team at Vanderbilt. This is our microbiology team and our COVID testing team. They're an absolutely fantastic group of folks. And I'm going to pass it over now to Dr. Snyder, who will be talking about automation and COVID-19. Dr. Snyder.
Thank you very much. And it's a pleasure to speak with you today. And thank you for your participation as well. And we're going to be speaking for a few moments on the total laboratory automation and how does this relate to COVID. And by way of disclosures, as I've listed here for you, the objectives for this presentation consist of primarily three. Share with you a little bit about our experience and the benefits of the TLA, the current Keister TLA, which we've had in our laboratory for nearly 3 years. And then the impact that COVID has had on our planning, our staffing, and testing while still trying to maintain our regular services as listed on the slide, including bacteriology and susceptibility testing and others. And then discuss our experience in a clinical trial that was performed with a research use only automated prototype. And I should acknowledge the fact that we were one of 2 laboratories in the world selected to do this clinical trial, the other being in Lausanne, Switzerland. some of you may have seen this in the Journal of Clinical Microbiology, but there's really a little controversy going on between these two individuals. One is highlighting, hey, we're really automated, TLA, and the other individual's kind of looking at him with some reservations. What do you mean total laboratory automation? You still have to do manual processing of some specimens, gram stains, and et cetera. So the question is it really total laboratory automation? And hopefully at the end of my presentation, I think you'll be convinced that total laboratory automation has arrived in the clinical laboratory. So let's start with a little bit about our impact of the COVID testing. I'm sure we're no different than any of you out there, but we had several challenges that were initially approached to manage the situation, such as testing capacity. How many could we do 24/7? How many platforms would we need for molecular testing? We had one at that particular time. We also, as all of you did, faced with the challenge of weekly allocation of reagents and kits, which forces you to strategize and to determine which platform is available to handle the current volume at that time, not to mention the swab and the transport supplies. I would also add into that bacteriological media, primarily for bacteriology as well as mycology, was also an issue that we had to deal with. And at the same time, we had the responsibility of maintaining our regular operations in the respective sections as you see them there, and at the same time be supporting the COVID testing, once again, 24/7. Probably our biggest challenge was testing personnel. We obviously got into a situation like, once again, I don't think we're any different than many of you out there, where we were testing a huge volume of COVID specimens coming in throughout the day and night. And so testing personnel was a challenge. And before the EUAs were available, that question was posed to the staff. And we asked, what are we going to do if we are going to be testing COVID, which we are. And based upon that particular discussion, we had decided we needed to increase primarily processors, not necessarily medical technologists, but we did bring on 3 or 4 additional processors who also were trained to load the keystra system. And with the automation provided by the keystra, these people were relatively free, or had more freedom to access, log in, and deliver the COVID specimens to the molecular diagnostics laboratory. You also had to deal with who gets tested first. And that's where we had to enter into conversations with lab management, chief medical officer, to determine who has priority. And I should also mention they wanted us to do the drive-through testing as well. And that was later on, but initially, and even still today, the emergency room has priority, our transplant patients and our pre-surgical patients. So it may differ in other institutions, but that is what has worked for us. But I have to say that the total laboratory automation was a significant factor in our utilizing not only processors, but some of our techs to train and supplement the current molecular diagnostic staff. And they were free to train on these different platforms. And we basically have seamlessly, for the most part, been able to meet our task and meet the volumes associated with COVID testing, which for us has not let up yet. So once again, it's one of those situations where prior planning is really critical. So why total laboratory automation? I've listed here several entities that explain or characterize why you want to consider total laboratory automation. I think the one thing that's driving it is we're being told or asked to do more with less. We're in the era of rapid diagnostics. Physicians know that, and they want their results as soon as possible. And other factors that you could see there, supporting antimicrobial stewardship, as Dr. Romney Humphries mentioned, support infection control and screen patients for hospital-acquired infections. And at the same time, provide rapid testing for COVID and hundreds of tests per day. I can summarize this very quickly. It's a matter of survival, not only for now, but in the future. So once again, to continue on with total laboratory automation, our experience has been that it has allowed us to reduce the time required to inoculate media by up to 70%. At the same time, it increases efficiency and productivity. And when you combine that with mass spectrometry, it allows you to optimize your workflow. It does reduce costs, which I'll show you later, and obviously time to pathogen identification. It does support our goal of becoming a 24/7 dedicated microbiology staff. We did get approval for creating a 24/7 dedicated microbiology staff, but COVID has put some hindrance in that at the point. We are reading plates and doing susceptibility testing up until about 11 o'clock. Then after that, we have to wait till the next morning. But we're on track to do that. And as I like to say to my administrators, microbiology is not designed to make money. Rather, it's to save money for the institution. And thus, I think that microbiology and the entire laboratory, for that matter, should be considered as a center of savings and not a cost center. So the advantages of automation, as many of you can already appreciate, is it standardizes, promotes uniformity and consistency. It does contribute to a reduction in technical errors, which I will address when we get into the experiences with the prototype that we'll talk about. It increases efficiency. That's a term that administrators like to use, along with increased productivity, and reduce labor costs. And labor costs is not intended to replace people, but to utilize more effectively your staff for other duties in either mycobacteriology, mycology, molecular, and so forth. So you don't necessarily have to add FTEs, but rather you utilize them more efficiently. So, as I said, we've been a TLA laboratory for the past 3 years that automates specimen processing in the system known as the inoculant. The culture plates are automatically transported to smart incubators, which are actually called RETAs. And digital imaging is really an advancement in assessing and evaluating the cultures, and the reduction in time to reporting. Currently, our plates can be read as early as 14 hours following inoculation. And the big factor contributing to that is the fact that the incubators are never open, so the temperature remains constant. It's same-day ID with MALDI-TOF, so we'll have that ID out in less than 24 hours usually. Antimicrobial susceptibility testing still requires overnight or 18 to 24 hours. But actually, we're getting our results or final results out for the most part in less than 48 hours. And of course, negative urine cultures can be read, eliminated, and finalized during that period of time. The big thing is the ergonomic benefits as well. The techs do not have to get up and down to retrieve or to add cultures to the incubators, and they are simply working at a workstation, doing everything on digital analysis. And the only labor comes in is when the culture is referred to what we call the picker bench, and the technologist at the picker bench calls or tells the incubator to send the plates to them. They already know versus the prior communication with the tech that read the plate, what colonies to pick and set up for MALDI-TOF as well as susceptibility testing. So the study objectives in this clinical trial that we were fortunate to participate in was actually to compare the performance in a clinical setting, in an everyday laboratory, of this fully automated RUO prototype the BD Keystra system, and I'll show you a photo of it here in a minute, with full automation of identification and susceptibility testing. I want to compare it to the current method, or what we call manual method, and involving the systems. Now, I will tell you that in the automated segment of the study, the BD Phoenix M50 was an addition to the laboratory as a separate standalone instrument, and in the automated system that I'll describe for a moment, there's also a Phoenix apparatus there. We obviously wanted to investigate the agreement between the two systems, automated versus manual, and then assess the potential of this automated system, which we refer to as the prototype, to enhance the operational and clinical performance because of the value of the automated colony picker, the preparation of the bacterial suspension, the spotting of the BD Bruker multi-top, the biotyper target plate rather, and inoculating the Phoenix M50 susceptibility panel. This is a photo of the prototype, and I will tell you right up front, this is not available for sale in the U.S. It's still, a large part of it is still in development. I would ask or recommend that you talk to your BD rep for any update on that. But this prototype that was placed in our laboratory, this is not a guarantee that this is what the final product is going to look like. But essentially, on the left side here, in the area called the Identifa, there is a Bruker, onboard Bruker. The colony picker is associated with the instrument as well. And on the right side is the automated susceptibility testing module. And as a result of that, you have both in one system here. This is the Bruker that sits in our laboratory, and I'm sure in many of yours. Once again, we had the M50 Phoenix associated with the study as well, because that was part of the manual aspects of the study. So the specific performance criteria that we were interested in were the percent of isolates can be identified, the average identification score compared to manual identification. It wasn't a major part of the study, but we did want to know the estimated labor costs, and we will present that in a few moments. And some of the other performance criteria that we evaluated. And I should mention that this paper, along with our colleagues in Switzerland, are both published. We published our paper in Clinical Microbiology and Infection in July of last year, and our colleagues in Switzerland published theirs in October of last year. Two totally independent studies, both of which are published. So the methods briefly were the isolates were selected by technologists from our specimens that were eligible in his or her mind, clinically relevant for further ID and AST. And then that was followed by 3 to 9 well-isolated colonies selected manually for the current manual preparation. So the current manual preparation was select the colonies, manually spot them on the multi-top, prepare a standardized suspension, and inoculate the Phoenix system. These colonies were also marked in the digital images for automation. So the technologists that were associated with the automated port knew what colonies, 3 to 9, were to be picked from the digital images. And as I said, the onboard picking system actually did the picking or the acquisition of those colonies. And it prepared it for both ID and susceptibility testing, once again, with the onboard multi and onboard Phoenix. I should point out that in the manual system, there was actually 2 separate inocula that were used, one for the ID, one for the AST, which, as everyone knows, can be a variable. But it was a single inoculum in the automated segment of the study. IDs were repeated manually from a subculture of well-isolated colonies if the multi scores were were less than 1.7, or the automated system and the manual system yielded discrepant IDs. So ASTs were repeated if there were major categorical differences of MICs, and they had to differ by more than one doubling dilution. If discordant results were observed or recurred in the repeated test, these isolates were then referred to testing by the microscan, which is our primary system for susceptibility testing in our laboratory. And ultimately, the microscan was the referee for discordant results. So we initially, you can see here, we had 523 total isolates evaluated, representing a variety of clinical specimens. And as a result of that, we thought we had a good representation of the distribution of isolates. A large number, of course, gram-negative. I point out that Enterobacter aerogenes, as you know, is now Klebsiella aerogenes, and as a result of that, at that time, the Bruker database had not updated the Klebsiella. So that's why I wanted to point out the Enterobacter. And these are mostly the gram-positive organisms. We had 3 of the 520 that simply did not give peaks on the MALDI in both the automated as well as the manual system. So 520, but overall the data will represent 523. So if you look at the MALDI scores, once again, less than or equal to 1.7, in the above section here, this is the initial testing of these 523 isolates. And as you can see, that 86.9% scored greater than 2, 2.1%, as you can see, scored between 1.7 and 1.99. And what this actually indicates is that before repeat testing, there was an 89% and 92.9% respectively, automated and manual, that had scores in the range that you see here. Once we repeated those, I think there were 57 isolates or something like that, we increased that to 97%, and the manual system was 98%. So there was very, very close agreement there between the two. So some of the problems we noticed in the identification portion was there were occasional incidents of inaccurate automated multi-TOF target spotting, but I can assure you that the major problems in spotting were through the manual method. We had more errors with that. And as you know, spotting a multi, as far as I'm concerned, is an art, and it takes skilled technologists to effectively spot the multi template. There was also occasional difficulty in testing mucoid isolates, pinpoint or small colonies, and some streptococcus isolates gave us problems. There was also, as I indicated earlier, occasional incidents where peaks were absent, and this occurred on both automated and manual. And then we attributed the scores below 1.7 to be result of low turbidity or low biomass. And note that the BD Keystra Identifa A will always, regardless of the density, process for MALDI and so forth, even if the McFarland standard is below 0.2. So the benefits of automated identification, we found it was rapid, it was accurate, reliable. We'll show you that it was cost effective. It did promote increased productivity and efficiency. And really the nice or highlight is standardization and uniformity. And we also noticed very minimal maintenance, which is something you need to take into consideration. Of the AST results, we had 7,512 evaluable drug bug organ tests. And as a result of that, the overall percentage of accuracy was 98.7%. We also noticed that over 1,600 of these combinations both methods yielded on-scale results, that is, a definitive MIC. I'll say a little more about the cost here in a moment, and it's very significant. Overall, there was essential agreement between the two systems of 98.7%, which is very good, and categorical agreement, almost 98%. Once again, very good. And there were very few major categorical discrepancies. Table 7 refers to that table, which is in the publication. So if we looked at our labor costs, and it's strictly labor, not including reagents and so forth, we found that in the manual versus the automated system, it was 83 cents to identify one isolate, and for 16 isolates, which was the number of isolates we tested at one time, it's $13.20. The isolates, the same process for the automated, it cost us 5 cents for both ID and susceptibility testing. So the total labor saved is quite significant, as you can see here. And then the susceptibility testing, we saved for 100 isolates this amount of money. If we take this and put it on a monthly basis and estimate our workload of 1,000 isolates per month, we could then see a savings of over $2,300 in a month, or annually a savings of $28,266. And that's significant information that you need to provide to the administrators. So the benefits: reduced hands-on time, no question about it. That reduces labor, does not replace people, improved efficiency, once again, increased productivity, standardization really eliminates technical errors that can occur with manual processing. I mentioned a little bit about improved ergonomics. It did potentially, if we were to use it, would optimize our workflow, and also promotes greater chemical and biological safety. So in summary, there was excellent agreement and analytical performance of this fully automated system. Significant advantages, as I've already have mentioned, such as efficiency, standardization, reproducibility. And the addition of this system to the current TLA in the Keystra system is going to be a tremendous asset. Matter of fact, we have it in our budget when the system becomes available. So with our current TLA, we were better able to use our personnel resources for COVID testing. And once again, it frees people up to do other things. And the controversy that was initiated at the beginning, I think we can say at this point, total or full laboratory automation has become a reality, and very excited about that. And I hope sometime we can have a full automation concept for testing all these COVID specimens. And I'm sure, like you, we are tired. Morale is a little low with all the COVID testing coming in. And rather than 4 platforms, I'd like to see one platform that can handle it all, very similar to the lab automation that we just described. So with that, I want to acknowledge my team, and they worked very hard on this for about almost 5 months. And I should recognize Dr. Ken Thompson, who handled all the susceptibility aspects of the study, including the management of the data. So with that, I will thank you and turn it back over to our moderator.
And thank you, Dr. Snyder and Dr. Humphries, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have any questions you want to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. So let's get started. It looks like we already have some great questions coming in from our audience members. Our first question: what additional benefits were observed from the overall TLA system, the automated streaking and incubation?
Well, the primary benefits were the result of standardized streaking of plates as opposed to manual streaking of plates. You know, no one individual streaks the same way, But with the automation, the plates are standard and reproducible on every plate. The other is the automated inoculation of the specimens. Once the specimen is identified in the Keystra, it talks to the inoculant. It automatically sends the appropriate media to the inoculation station, and each inoculum consists of 10 microliters, followed by the use of a magnetic bead that streaks the plates. Once they're streaked, they are taken automatically to the smart incubators. So standardization and uniformity.
Thank you so much. Now, is the Stenotrophomonas considered a gram-positive organism now that the speaker had included it with gram-positive organism group?
Well, it's gram-negative, but it could have been a misplacement of the organism, but steno is a gram-negative rod.
Thank you very much. And I want to thank our audience for these great questions coming in. We have time for a few more. What aspect of automation has been the most impactful to your lab?
I would have to say from our perspective is better utilization and more efficient utilization of personnel. We did not have to increase FTEs. And the only thing we've added, and primarily because of COVID, were lab assistants to do processing. But once they put the specimen on the inoculant, they're free to do something else. And free to do something else translates into our world as answering the phones that ring all day.
Thank you so much, Dr. Snyder. And are you seeing a greater appetite for administrators to invest in technologies to automate routine processes?
I will say somewhat. I don't know how it is in the other participants' laboratories, but all our administrators are focused on is COVID. They don't want to talk about anything else. But if I can tie whatever it is to COVID, then I get their attention. We wanted another instrument, and I said this would really be of great value in our support of COVID testing, and I had it within a month. So it depends upon how you present it and the value added, and in this case, the value added was improving COVID testing and reducing turnaround time.
Thank you so much. And we have one more question, and this one's for Dr. Humphries. Can you tell us how COVID will impact the microbiology operations long-term, Dr. Humphries?
Yeah, that's a great question. I think, as Dr. Snyder kind of went through, we're learning a lot about our workflow and how to make our processes as efficient as possible. This can be really tricky to manage, but the end of the day, especially going through this pandemic, if something isn't value added, it needs to be cut. So that's one big thing. And I think that we will see a movement towards more automation and hopefully just, general increased awareness of the value that the lab provides, as well as, in particular, the clinical microbiology infectious diseases labs.
Thank you so much, Dr. Humphries. And Dr. Snyder, we have actually one more question for you, and we have time for that question. Could you affirm that having the entire diagnostic processing automated, you are allowed now to do better advisory tasks in the antimicrobial stewardship demands?
No question about it, but it also gives the opportunity to build up your other sections, such as the mycobacteria, the mycology, and other areas, including molecular diagnostics. We're moving forward in our molecular diagnostics for bringing on new tests. With this automation, that's going to make it much simpler or easier because we'll have more time to focus on it.
I want to thank you so much, both of you, for your time today. Would you like to provide some closing remarks for our audience? I'll start with you, Dr. Humphries.
I think that the biggest thing is that lab testing is important. We've seen that. We've seen how important it is. And I think, you know, we all in the clinical labs do our best to have the best quality results. And at the end of the day, I hope we all can appreciate how much impact that can have on patient care and management, you know, during a pandemic, but also outside the pandemic.
Absolutely. And Dr. Snyder?
I think the last year has brought the laboratory to the highest level of visibility than ever before. That is, the administrators and the management really don't understand who microbiology or the laboratory as a whole is and what they do. They look at it as a necessary evil. But I cannot tell you how much attention the laboratory has gotten from the higher ups, if you will, and saying, gee, you guys really do contribute significantly to patient care. And we look at them and say, that's all we do. And as a result of that, I would encourage everybody to consider reading the recent Journal of Clinical Microbiology with Dr. Lanaz Samuel's paper in there regarding the need for dedicated microbiology leadership in the clinical microbiology laboratory. I am very proud of what I do. I know Dr. Humphries is as well, but I'm most proud of our technologists who are really the ones that make us successful because they're committed to what they do. So with that, I will turn it back to you.
Well, Dr. Snyder and Dr. Humphries, thank you again for your time today and for your important research. And before we go, I want to thank the audience for joining us today and for their interesting questions. Questions that we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. And I'd also like to thank LabRoots and our sponsor BD for underwriting today's educational webcast. You can view this webinar on demand, and LabRoots will alert you via email when it's available for replay. That's all for now. Until next time, take care and stay safe. Bye-bye, everyone.